Welcome to the deep dive. This is not a slow introduction. This is an activation drill. We're diving immediately into the highest stakes material you face on your final exam. Pediatric communicable diseases, the U.S. immunization schedule, and the clinical prioritization that separates passing scores from the rest. Our mission today is pure, compressed clarity. We are taking all your key points, your lecture notes, and the common pitfalls from your practice questions, and we are locking them in through pattern recognition.
That's absolutely right. Think of us as your clinical study partners, making sure every single nugget of information sticks in the right context. We know you know the basics. Today is all about strengthening that recall, avoiding those tempting NCLEX distractors, and making sure you immediately recognize the red flags that demand priority nursing action. We're going to move fast, but we'll anchor the critical why behind every clinical decision.
Okay, let's do it. Let's unpack this entire unit into the major themes that really underpin the exam questions. I see three massive categories that are going to test your critical thinking. First, recognizing pattern recognition. This is all about the ability to instantly differentiate the viral rashes, the exanthems, by their fever sequence, their rash appearance, and their specific prodrome symptoms. If you mix up measles and roseola, you mix up the isolation type, and that's a safety fail.
It's a huge safety fail. And the second theme is just as critical: mastering vaccine mechanisms, safety, and schedules. You absolutely have to know the difference between active and passive immunity, and who can receive a live vaccine versus who absolutely cannot. Plus, those crucial timing rules, like when a Tdap booster changes from that 10-year rule to a 5-year rule. The questions here, they test your attention to detail and patient safety above all else.
And critically, the third theme, which is pure prioritization: infection control and perfusion crisis management. This means immediately applying the correct isolation, airborne, droplet, or contact, and most importantly, recognizing the subtle early signs of shock and sepsis in a pediatric patient. This, combined with knowing the non-negotiable rules for fever management and correct antipyretic dosing, well, it dictates life-saving action.
Exactly. So to achieve this level of dense coverage, we're using a 5-point structure for every concept we review. We'll start with a rapid concept summary, covering the pathology and core key points. Then we hit the hallmarks and red flags, what you must recognize immediately.
Or the two first.
Right. Following that is priority nursing actions. Then the detailed NCLEX trap defense, how to avoid the common mistakes. And finally, a tight memory anchor to lock it all in.
Okay, let's start with the viruses that announce themselves with a rash.
The rashes, they're tricky because, they can all look similar if you aren't paying close attention to the fever and the timeline.
That prodrome, right, the symptoms before the rash. That's the clinical P.
Absolutely. The exam relies on you differentiating based on that exact sequence.
Okay, let's hit rubella first, often called German measles. This is typically a milder, much less severe illness in the child compared to, say, rubeola. The key pathophysiology note is that it's caused by a virus, usually presents with a low-grade fever, and this fine, pinpoint, slightly icky rash that starts on the face and just rapidly spreads downward.
And the most distinctive physical finding in that prodrome phase is the posterior auricular lymphadenopathy.
Swollen nodes behind the ears.
Exactly. Swollen nodes right behind the ears.
Now, contrast that immediately with measles or rubeola. This is a far more serious, highly contagious viral respiratory illness.
Right. And the defining factor is the fever. It is high. It spikes off into 104 or 105 degrees Fahrenheit. It's a big deal. And the prodrome is profound and lengthy. It lasts 3 to 5 days before the rash even shows up. And it's defined by the 3 C's.
Cough, coryza, and conjunctivitis.
Right. Severe runny nose, red, watery eyes. And the rash itself is maculopapular, much blotchier, and also starts on the face and head before spreading down to the trunk and extremities. It fades in the order it appeared.
Okay, and then the critical pattern breaker, roseola infantum, caused by human herpes virus 6. The patho here is less about the rash and more about the body's response to the virus. What's the timing sequence that defines roseola?
The defining sequence is totally unique among the exanthems. The child will present with an abrupt onset of extremely high fever, again, up to 105, but they look disproportionately well for that level of fever. This goes on for 3 to 5 days.
And they're most contagious during this high fever phase.
That's the key. Then, crucially, on or about the 5th day, the fever just resolves. It suddenly drops to normal, and only then does the characteristic rose-pink, non-pruritic rash appear, starting on the trunk and neck.
Okay, we need immediate visual identifiers. For measles, the non-negotiable hallmark, what must be recognized, is the cough lick spot. Where and when do we see them?
You find them on the buccal mucosa, the inner lining of the cheek, 1 to 2 days before the generalized skin rash ever breaks out. They're described as these small, irregular red spots with a tiny central bluish-white speck. If you see those, you have measles, and you have to act on isolation immediately, even before the rash confirms it.
Now, the massive clinical red flag for rubella. If it's such a mild illness, why is it tested for so rigorously in the clinical setting?
Because the mildness in the child hides a catastrophic threat to the fetus. The red flag is the extreme teratogenic risk if a woman contracts rubella during the first trimester of pregnancy. This leads to congenital rubella syndrome, or CRS, which includes severe permanent birth defects, profound deafness, cataracts, cardiac defects like PDA, intellectual disability, microcephaly.
And that classic visual description.
The blueberry muffin baby, that's
Yeah.
due to the petechiae and purpura, and that's why immunity screening checking that IgG status is non-negotiable for all women of childbearing age.
And the roseola hallmark, again, is that inverse relationship between fever and rash.
Yeah.
What red flag comes from that rapid, prolonged fever?
The fever breaks as the rash appears. That pattern is diagnostic. The associated red flag is the high risk for febrile seizures during that initial high fever phase, especially since roseola typically affects infants and toddlers who are most susceptible to those rapid temperature spikes.
So nursing actions have to include teaching parents seizure precautions.
Absolutely. And when to seek care.
Okay, isolation. This dictates your safety prioritization. For measles, why is airborne necessary? It's the most stringent requirement.
Measles is incredibly infectious and highly stable in the air. Its particles are tiny, they're aerosolized, and they can linger in the air for up to 2 hours after the infected person leaves the room.
Wow, 2 hours.
Yeah. Therefore, it requires airborne precautions, an N95 mask for staff in placement in a negative pressure isolation room.
And rubella.
Rubella is spread by larger respiratory droplets, so it requires droplet precautions. A standard mask, patient cohorting.
And roseola is just standard or contact.
Primarily, yes, emphasizing hand hygiene as it's spread through respiratory secretions and saliva.
Let's focus on the pregnant patient exposure again. If a non-immune pregnant woman is exposed to measles or varicella, what is the priority action and timing?
The priority is post-exposure prophylaxis using passive immunity. This means she must receive varicella zoster immune globulin, or VZIG, or just immune globulin.
It has to be done fast.
As quickly as possible, yeah. Ideally within 96 hours of exposure to neutralize the virus and potentially prevent or at least minimize fetal infection. The high-yield nursing action for the infected child in all these cases is supportive, care hydration, rest, comfort, but strict, immediate isolation adherence is the fundamental priority.
Let's talk about the rubella trap in detail. The exam often uses that juxtaposition of severity.
Exactly. The trap is asking you to prioritize the risk. If a child has mild rubella, the risk to that child is low. However, if the question mentions a pregnant caregiver or staff member who is IgG negative, so not immune, the prioritization immediately shifts from supportive care for the child to immediate isolation and reporting to protect the fetus.
And you have to know the immunology.
You do. A positive IgM means an active acute infection. A positive IgG means immunity from past infection or vaccination. If they test a pregnant patient and find they are IgG negative, that patient is completely vulnerable. That is a massive red flag.
What about the roseola trap involving fever management?
They try to trick you into performing aggressive cooling measures or focusing on the rash. The rash is benign, it's non-pruritic. The focus has to be on seizure prevention during the high fever phase and hydration. Once the fever breaks, the child is rapidly improving, so your intervention should reflect that. Comfort and observation, not alarm regarding the rash.
Okay, let's lock in the memory anchors. For rubella, mild fever, big pregnancy problem.
For measles, IgH fever, 3 Cs, Koplik.
And for roseola, fever first, rash after.
All right, moving now to conditions that carry a more immediate risk. Complications, severe respiratory compromise, or they demand antibiotic intervention.
These are the immediate calls to action.
We're targeting varicella, pertussis, and scarlet fever. Isolation, treatment, and complication recognition are paramount here because the stakes are much higher than with the benign viral exanthems.
Varicella, or chickenpox,
Hmm.
caused by the varicella zoster virus. The key pathology is that rapid progression of skin lesions. They start as macules, quickly become fluid-filled papules, then vesicles, and finally they crust over. What's the single most important descriptive note about the lesions for diagnosis?
That the lesions are present in various stages of healing simultaneously on the same person. You'll see fresh vesicles right next to crusted scabs. The rash is typically centripetal, so it spreads primarily on the trunk and face before it gets to the limbs.
And for safety, you have to remember its infectious period starts 12 to 24 hours before the rash even appears.
Which makes containment so difficult.
Okay, scarlet fever. This one's bacterial. Group A strep.
Right, Streptococcus pyogenes. The rapid concept is that it follows a sore throat or tonsillitis. The characteristic rash is due to the release of an erythrogenic toxin that the bacteria produces, which causes that diffuse redness and the specific texture.
And finally, pertussis, or whooping cough, another bacterial threat.
Bordetella pertussis. The core pathology here is that the bacteria attaches to the respiratory cilia and releases toxins that paralyze them. This causes swelling and inflammation, which prevents the effective clearance of mucus and leads to those uncontrollable coughing fits.
It has two distinct stages.
Yes, the mild, non-specific catarrhal stage, think mild cold symptoms, and then the dangerous paroxysmal stage, which is where you see the severe coughing fits.
Okay, varicella hallmark, the iconic dewdrops on a rose petal visual. And was the most common clinical requirement for returning to school or ending isolation.
Isolation is mandatory until all lesions are fully crusted over. No exceptions. The critical red flag with varicella is the risk of severe complications, like secondary bacterial skin infections, pneumonia, or encephalitis, especially in immunocompromised or non-vaccinated individuals.
Which would necessitate a cyclover use in those high-risk groups.
Exactly.
Scarlet fever hallmark.
The distinct sandpaper rash sensation, it usually blanches when you press it. It often starts in the folds, like the groin and armpits, before spreading. And coupled with that rash, you look for the exudative tonsillitis and the strawberry tongue.
That starts white, then peels to red.
Right. And the major red flag here is the potential for non-suppurative complications, specifically rheumatic fever, which can damage heart valves and cause carditis, and post-strep glomerulonephritis. Proper antibiotic treatment within 9 days is absolutely essential to prevent rheumatic fever.
And pertussis.
The hallmark is the paroxysmal cough, these rapid consecutive coughs, followed by that high-pitched inspiratory effort, the whoop. But, and this is important, in infants under 6 months, they may not have the strength to produce the whoop. Instead, the red flag for them is apnea stopping breathing and potentially cyanosis after a coughing fit.
And the post-tussive vomiting is also a big sign.
A critical sign, yes. It's common after a severe coughing spasm and can lead to dehydration and weight loss.
Okay, isolation review. Varicella versus the bacteria.
Varicella remains airborne. Both scarlet fever, due to droplets from the throat, and pertussis, from the violent coughing, are managed with droplet precautions.
And since scarlet fever is bacterial, the priority management is antibiotics.
A full course of penicillin or amoxicillin, yes, to eradicate the strep and prevent those delayed complications like rheumatic fever. For pertussis, we use macrolide antibiotics like azithromycin to shorten the contagious period.
Let's elaborate on that high-yield pertussis prevention measure, especially for newborns, the cocooning strategy.
The newborn is so incredibly vulnerable and can't complete the detox series until they're 6 months old. So cocooning is the strategy of vaccinating the immediate circle of contacts, parents, grandparents, caregivers with Tdap. And most critically, the mother should receive the Tdap vaccine during every single pregnancy, specifically between 16 and 32 weeks gestation.
Why then?
To maximize the maternal transfer of antibodies across the placenta, giving the infant some temporary passive protection.
Okay, NCLEX trap defense. The varicella trap often focuses on a subtle complication that leads to a safety issue.
Yes, the trap is focusing too much on the skin rash and forgetting the mucous membranes. Varicella lesions are really common in the mouth and throat. They're incredibly painful, which leads to the patient refusing to drink or swallow. This makes dehydration the primary complication in an otherwise stable patient. So the nursing priority shifts to strict fluid intake monitoring and pain relief for those mouth sores.
And the pertussis trap involves timing and patient education.
Oh yeah, the exam loves to test knowledge of contagion timing. Students often assume the patient is most contagious when they're actively whooping in that paroxysmal stage. But in reality, the patient is most contagious during the early, mild, cold-like symptoms, the catarrhal stage, before the whoop ever starts.
So a question might ask when to isolate a child who had mild cold symptoms last week and just started whooping today.
Exactly. And isolation should have started earlier, but the child is still contagious for about 2 weeks after the cough begins.
Okay, memory anchors, varicella, vesicles, different stages, crust.
Scarlet fever, Sandpaper, strawberry, strep A.
And pertussis, night cough, whoop, vomiting.
All right, this next cluster is pure mechanism, safety, and recall. We have to distinguish between active and passive and live versus inactivated because this determines whether a vaccine is safe for an immunocompromised host.
Precision is absolutely key here. A mistake here is a massive safety violation, and the NCLEX focuses heavily on the contraindications for live vaccines.
Let's revisit immunity. Active immunity is the goal of vaccination. It's when the body encounters the antigen from the vaccine or natural infection and makes its own T and B cells and antibodies.
This is lasting immunity.
This is lasting immunity. Conversely, passive immunity is when preformed antibodies are given to the patient, like receiving immune globulin or the transfer of maternal IgG across the placenta. It provides immediate, temporary protection, but the body didn't do the work, so it does not confer lasting immunity.
Okay, regarding preparation. Live vaccines, like MMR, varicella, rotavirus, and the nasal flu vaccine, LAIV, they use a weakened form of the germ. Why are they so effective?
Because they closely mimic a natural infection. They stimulate a really robust cellular and humoral response, which leads to strong, long-lasting immunity and often requires fewer doses.
On the other hand, you have inactivated or killed vaccines.
Like ITV, Hep A, Hep B, DTaP, they use the killed germ. They're safer in compromised hosts, but they require multiple doses and boosters because the immune response they generate is weaker and less durable.
Let's get to the most critical safety red flag in this entire unit. Who absolutely cannot receive a live vaccine?
The immunocompromised patient and the pregnant woman. These are absolute contraindications for live vaccines, MMR, varicella, rota, LAIV.
And by immunocompromised, we mean
children on high-dose corticosteroids, chemotherapy, those with severe congenital immune deficiencies, or those with symptomatic HIV. Giving a live vaccine to these patients risks the weakened virus actually disseminating and causing the disease. Safe alternatives must be used.
Let's dive deeper into that timing complication. Why do we have to delay live vaccines if a child receives passive immunity?
Because the passively administered antibodies from IVG or blood products are circulating and programmed to attack foreign antigens, so they will neutralize the weakened virus in the live vaccine before the child's active immune system can even respond.
Which renders the vaccine ineffective.
Totally ineffective. The critical timing delay you have to remember is up to 11 months after receiving IVIG or a blood product transfusion.
And what about that crucial storage safety alert? Why is the refrigerator door a danger zone?
Vaccine potency relies entirely on maintaining the cold chain, a constant, precise temperature range. The refrigerator door experiences the most significant temperature fluctuations from being opened and closed all the time, and that compromises the vaccine's efficacy.
It's a subtle but critical safety point the exam uses to test safe administration practices.
Definitely.
Okay, priority nursing actions. Flawless documentation is a legal and public health priority. What are the essential 6 data points that must be included on every vaccine record?
Okay. Date. The specific vaccine given, the site and route, the administrator's name and address, and, critically, the manufacturer and the lot number expiration date.
The lot number and manufacturer seem really important.
They're non-negotiable, because if a badge is ever recalled or linked to an adverse event, public health officials have to be able to track every single dose administered. And of course, the parent must receive the Vaccine Information Statement, or VIS, which details risks and benefits, before administration.
And pain minimization.
Yeah.
That enhances compliance, right, which is a key health promotion strategy.
Mm.
What are the high-yield methods for minimizing injection pain in infants?
Distraction is effective for toddlers, for sure, but for infants up to about 4 months, the gold standard is sucrose water. That's an oral glucose solution on a pacifier, given just before and during the injection.
And what about multiple shots?
Simultaneous injections, if multiple doses are due, are preferred over multiple visits, and administering the most painful vaccine last can help. You have to use age-appropriate distraction and be honest with older kids.
Finally, emergency response. If you see signs of anaphylaxis, rapidly developing laryngeal edema, wheezing, hypotension, widespread hives, what is the immediate priority?
Stop the administration immediately. Call for assistance, ensure the airway is patent, and administer epinephrine, EpiPen, or injection per protocol. And you have to be able to differentiate this from common expected systemic reactions like a low-grade fever, fussiness, or local redness.
Which are managed supportively with comfort care and antipyretics. Okay, schedule traps. You have to memorize the adolescent visit.
The 11 to 12-year visit is a cluster of 3 critical vaccines: HPV, Tdap, and MenA-CWY, the meningococcal conjugate vaccine. Missing this cluster leaves the adolescent vulnerable.
And here's a nuanced but frequently tested trap: the dosing trap involving tetanus. For routine boosters, Tdap is every 10 years.
But for a highly contaminated dirty wound, a burn, or a puncture wound where tetanus risk is high, the rule changes. A TD or Tdap booster is required if the last dose was more than 5 years ago, not 10. The higher risk necessitates accelerated protection.
And the immunity trap regarding why infants get sick so easily.
The exam distractors, they try to confuse you by suggesting maternal antibodies are the issue or lack of hygiene. The primary reason is the immature immune system, which has limited exposure and lacks sufficient active antibodies or robust T-cell function to fight off common pathogens.
So those maternal antibodies are only temporary.
Right, they provide some protection, but they wear off rapidly, leaving the infant vulnerable until they complete their primary series. It just highlights the importance of those scheduled visits.
Memory anchors. Live equals strong immunity, but NO for weak systems.
Tdap at 11, T'd every 10, but 5 for a nasty wound.
And one more. Delay live after IVG for 11 months.
All right, this last cluster is pure foundation, patient safety, early recognition of decline, and correct dosing. Getting this wrong impacts every patient, regardless of the disease.
We have to drill down into the physiological rationale behind our fever management and the critical early signs of pediatric shock, which often manifest differently than in adults.
Let's start with pediatric vulnerability. Why are children, especially infants, uniquely susceptible?
They have an immature immune response, limited prior exposure, and behaviors like mouthing objects and poor hand hygiene. And crucially, they often can't articulate subjective symptoms like pain or malaise, so nurses have to rely entirely on objective, subtle changes.
Regarding fever, we define it as a temperature over 38 degrees Celsius or 100.4 Fahrenheit. The rapid concept you have to retain is that fever is often a friend, not an enemy. It's a beneficial compensatory mechanism. It enhances the immune response by increasing the activity of white blood cells, boosting interferon production, and accelerating antibody synthesis.
So our goal isn't necessarily to normalize the temperature.
Exactly. It's to manage symptoms for comfort and prevent complications.
But when that infection overwhelms the system, we face sepsis.
Sepsis is the body's dysregulated systemic response to an infection. In children, it can progress extremely rapidly to septic shock and organ failure. The priority is early recognition before hypotension sets in, because pediatric patients compensate for a long, long time. And once their blood pressure drops, they are often on the verge of cardiopulmonary arrest.
Okay, hallmarks and red flags. Let's start with prevention. What is the single foundational #1 prevention hallmark that is always the priority intervention?
Hand hygiene. It's simple, it's effective, and it is always the first line of defense against the transmission of pathogens. It surpasses any medication or isolation measure.
Now, the critical sepsis red flags related to perfusion failure. What specific signs indicate the child is compensating poorly and shunting blood away from the periphery?
You have to look for the signs of poor circulation. Tachycardia is often the earliest sign of compensatory shock. The heart beats faster to maintain cardiac output against dropping systemic vascular resistance.
And then the peripheral changes.
Right. Look for prolonged capillary refill time, so more than 2 seconds, mottled extremities, that patchy discoloration, and critically signs of poor organ perfusion like decreased urine output, which would be less than 1 to 2 millimolars per kilogram per hour. These signs demand immediate fluid resuscitation and intervention.
When does a fever absolutely transition into an emergency?
The rules are strict. 1, any fever, so 38 Celsius or 100.4 Fahrenheit, in an infant less than 28 days old is an automatic mandatory red flag. It requires immediate hospitalization and a full septic workup labs, urine, often an LP. They just lack the ability to localize infection.
Okay, what's rule #2?
A fever greater than 41 Celsius or 105.9 Fahrenheit in any child. And 3, any fever accompanied by a toxic appearance marked lethargy, unresponsiveness, poor color, or cyanosis, regardless of the temperature height.
For fever management, let's be explicit about the core safety rule regarding medication.
The safety rule. You must administer only one antipyretic, either acetaminophen or ibuprofen at a time. Never alternate or combine them unless specifically ordered, because the risk of accidental overdose and subsequent liver or kidney toxicity is just too high. This is a crucial safety violation trap.
And regarding dosing, why do we prioritize precise dosing calculations?
Because medication doses in pediatrics are weight-based, milligram per kilo, not fixed. You have to be able to perform this calculation rapidly and accurately, and you must educate parents to use weight-based calculations and never use household teaspoons or tablespoons for measurement. They are not accurate.
Only calibrated syringes or dosing cups?
Yes. And remember the numbers. Acetaminophen is 10 to 15 milligrams per kilogram per dose. Ibuprofen is 4 to 10 milligrams per kilogram per dose.
Beyond medication, what are the supportive priority actions for fever?
Hydration is key. Fever increases metabolic rate and insensible fluid loss, leading quickly to dehydration, so you encourage extra fluids. We also remove unnecessary clothing to facilitate heat dissipation. And the ultimate non-negotiable newborn rule. Fever in a newborn is 9/11. It warrants an immediate, aggressive medical workup to rule out sepsis or meningitis.
Okay, what are the two dangerous, outdated methods of fever management that are often used as distractors?
Cold baths or alcohol sponging are incorrect. Applying cold or alcohol causes peripheral vasoconstriction, which actually traps heat in the core, potentially worsening the temperature. Plus, the shivering response dramatically raises the core metabolic rate and temperature.
And of course, no aspirin.
Never, under any circumstance, give aspirin to a child with a febrile illness due to the risk of Ray's syndrome, which causes acute encephalopathy and liver failure.
Another trap involves transmission-confusing diseases that require isolation with those that don't spread person to person.
Right. We have to distinguish vector-borne diseases transmitted by ticks or mosquitoes from droplet or contact spread. So Lyme disease, Rocky Mountain spotted fever, and malaria are not spread person to person.
So the trap might ask how to protect a sibling from a child with Lyme disease.
And the answer is not isolation, but environmental safety, like doing tick checks.
Okay, memory anchors. Hand hygiene saves the day.
Newborn fever is 9/11.
Only one antipyretic.
Okay, now we shift gears to critical reasoning. We need to connect, contrast, and integrate this information, specifically focusing on lookalike conditions and universal nursing strategies that apply across multiple diagnoses.
This is where we build the complexity required for true final exam success.
We're moving beyond isolated facts and building the clinical matrix. We'll compare two rashes that are often confused, contrast two non-rash viruses with high organ risk, and consolidate the isolation rules and pharmacological strategies.
Let's start with fifth disease erythema, infectiosum, and scarlet fever. One is viral, one is bacterial, and confusing them means missing antibiotic treatment.
The anchor for fifth disease, caused by parvovirus B19, is the unmistakable slapped cheek appearance, that intense redness on the face, sparing the area around the mouth. This is followed by a classic lacy reticular rash that spreads onto the trunk and extremities.
And the child is often contagious before the rash.
Right, and treatment is supportive care because it is viral. The rash can also fade and reappear with environmental changes like sun exposure or heat.
Contrast that with scarlet fever.
Scarlet fever is the sandpaper rash and the strawberry tongue. The distinction is the pathogen. It's bacterial, strep A, and therefore requires a full 10-day course of penicillin or amoxicillin. This is to prevent the massive long-term risk of rheumatic fever and carditis. You can never confuse the viral benign fifth disease with the bacterial high-stakes scarlet fever.
And the presence of a sore throat and fever history points toward strep.
Exactly.
Okay, let's contrast neuro and organ red flags. Mumps versus mono. They're two non-rash viral syndromes, but they carry high risk to specific organ systems.
The hallmark for mumps is the characteristic swelling of the parotid glands, that painful swelling below the ear, often called the hamster face, with pain that's aggravated by chewing. Mumps requires droplet precautions. The complications focus on the reproductive and nervous systems. Orchitis, which is testicular inflammation common in postpubertal males, oophouritis, and meningitis.
Now, mononucleosis, or mono, caused by the Epstein-Barr virus. The symptoms are generalized and vague, but the red flag is highly specific.
Mono symptoms are generalized fever, sore throat, extreme debilitating fatigue, and enlarged lymph nodes. But they're often accompanied by hepatosplenomegaly.
Enlargement of the liver and spleen.
Right. Mono is primarily spread through saliva, the kissing disease, and requires contact precautions. The key teaching point is related to the spleen. The patient must observe NO contact sports for at least 6 to 8 weeks or until swelling subsides.
Because the high risk of splenic rupture from trauma.
Exactly. This safety instruction is mandatory for discharge teaching.
Okay, let's nail the isolation matrix. This determines your room placement, staffing assignment, PPE use. It's pure prioritization based on transmission risk.
We have to know the mechanism. Is it tiny lingering particles, which is airborne, larger drops within a short range, which is droplet, or contact with surfaces and secretions, which is contact?
Which diseases require the strictest airborne precautions, demanding an N95 and negative pressure?
Measles, or rubeola, and varicella, which is chickenpox. The high infectivity and aerosolized nature demand this high level of protection.
Which require droplet precautions. So, a standard surgical mask.
Droplet precautions cover respiratory viruses and certain bacteria spread by close contact. So, rubella, scarlet fever, pertussis, mumps, diphtheria, and fifth disease.
And finally, contact precautions, emphasizing hand hygiene and gown and gloves for close care.
Conditions spread by direct contact with secretions or fluids. So, mononucleosis, hand-foot-mouth disease, roseola, and certain bacterial infections like major staph or colonization, and GI issues like rotavirus.
Let's connect the farm strategies across systems. We've hit on vaccines and antibiotics, but let's connect the overarching strategies, specifically passive immunity and the complex DTaP protection.
The most sophisticated safety concept with live vaccines is the duration of the delay after receiving IVIG or blood products. We said the delay can be up to 11 months. That number is important because it ensures the passively acquired antibodies are cleared from the child's system. If you give the MMR or varicella vaccine too soon, you have wasted the dose and left the child vulnerable, which means they'll need revaccination later.
So the key concept is passive immunity interferes with active immunity.
Exactly.
Let's discuss the three components of the DTaP series and the distinct, severe threats they prevent. This is universal health promotion and disease prevention.
DTaP protects against three completely different pathological threats. Diphtheria is a bacterial infection that causes a thick, gray, leathery pseudomembrane in the throat, which can cause respiratory obstruction and releases toxins that damage the heart and nerves.
Scary.
It is. Then tetanus is caused by spores in the soil entering through wounds and releases a neurotoxin that causes painful muscle spasms and rigidity, the classic lockjaw. It is not spread person to person.
And finally, pertussis.
Right. Whooping cough, which we discussed, causes that severe cough and respiratory compromise. Knowing the gravity of these three diseases really underscores the absolute priority of adhering to the DTaP schedule.
Okay, we are entering the final rapid-fire round. This is the moment to check immediate recall. No deep dives, just the answer that secures the point.
Lock in the patterns. Let's go.
POP must know mechanisms. What is active immunity defined by?
Body makes its own antibodies lasting protection.
What is passive immunity defined by?
Antibodies given temporary protection.
Name the four major live vaccines.
MMR, varicella, rotavirus, LAIV.
When must live vaccines be delayed?
After receiving IVG or blood products for up to 11 months.
Hallmark symptoms you cannot miss. What is the hallmark of measles?
Koplik spots, high fever, 3 Cs.
What visual is diagnostic for scarlet fever?
Sandpaper rash and strawberry toe.
What is the primary risk and necessary teaching for mononucleosis?
Splenomegaly, no contact sports.
What is the key diagnostic sequence for roseola?
Fever breaks, then the rash appears.
What are the two diseases requiring airborne isolation?
Measles and varicella.
Red flags that demand priority action. What is the critical first sign of compensation in pediatric shock?
Tachycardia.
What is the mandatory safety alert temperature for a newborn?
Any fever, 38 Celsius or 100.4 Fahrenheit.
What is the consequence of rubella exposure in the first trimester?
Congenital rubella syndrome, leading to deafness and cardiac defects.
When does a highly infectious pertussis patient look the least sick?
During the catarrhal or mild cold stage.
Farm do's and don'ts. What is the absolute safety rule for fever reducers?
Do you give only one antipyretic at a time, acetaminophen or ibuprofen?
What is the contraindication for aspirin in children?
Ray's syndrome risk.
What is the Tdap booster requirement for a contaminated wound?
If the last dose was more than 5 years ago.
Most common NCLEX traps, recall check.
Yeah.
What is always the absolute #1 preventative action?
Hand hygiene.
What are the primary reasons infants get sick easily?
Immature immune system and low active antibodies.
What is the greatest risk in varicella cases with mouth lesions?
Dehydration.
What safety concern mandates the immediate workup for a newborn fever?
The high non-localizable risk of sepsis or meningitis. You have just internalized a vast interconnected web of clinical prioritization, pathology, and safety rules. goals. Remember, exam success is about recognizing these patterns and applying the safety first mantra, knowing that airway, breathing, and circulation trumps comfort, and that isolation and dosing safety trumps all else. That is the core of critical reasoning. Trust the patterns we reviewed: isolation, dosing, perfusion, and especially the contraindications for live vaccines.
That attention to detail is what will carry you through. Now, as you integrate this final compressed review, take one final expansive thought with you. We focus heavily on the domestic immunization schedule and the goal of herd immunity for our communities. But consider the logistics for global health. Given the sensitivity of live vaccines like polio and measles to temperature, how does the concept of the cold chain, that delicate temperature control system we discussed in storage, become one of the most significant logistical and ethical challenges when trying to achieve herd immunity in rural or developing areas across the world? Think about how climate and infrastructure fundamentally affect our ability to deploy these life-saving preventative measures internationally. Breathe deep, trust the patterns you've locked in, and go nail that exam.